Welcome to the OncoPT podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent OncoPT. Here's your host, Elise Cantu.
Hey OncoPT, and welcome back to this episode of the OncoPT podcast. We are continuing with another one of our research roundup episodes with our amazing research assistant here at the OncoPT, Dr. Kelly Martin. Now, Kelly, would you mind reintroducing yourself to our listeners who maybe haven't heard your voice on the podcast yet?
Absolutely, Elise. So my name is Kelly Martin. I am a physical therapist in North Carolina, and I practice currently in the outpatient setting. I see a good mix, but get to see a little bit of some patients with cancer diagnoses in my clinic as well, and trying to expand that horizon for myself.
Now, Kelly has been with the OncoPT team for several years now, and part of a big part of what she does these days is identifying different research roundup articles to review within our private OncoPT specialization community. And one such article that she brought to mind, I wasn't even aware was pertinent or relevant to oncology. And so when Kelly suggested this article, I was like, whoa. Back up, first of all, because I didn't even think this was possible. And I really appreciated how Kelly has this ability to find a lot of articles that are kind of outside of my very oncology focus and bringing in what we know to be working really well in other areas of physical therapy that maybe oncology needs to catch up on. So Kelly, would you mind introducing us to today's topic of our research roundup?
Absolutely. So the article that I found that I thought caught my eye and was really interesting is discussing blood flow restriction training in the oncology population, and kind of delves in terms of what literature is even available, the advantages that potentially are out there for this population, as well as some things. They touch on some points about safety and application of the actual cuff to patients. And so what's really interesting about it is that I use BFR. I have the opportunity to use BFR in my clinic setting in outpatient. And so I have really only applied it mostly with our post-operative population. So post-op ACL, joint replacement, other scope surgeries, whatever, when the idea is that the body at that time, the tissue, the healings that's happening in those early phases of rehab doesn't allow us to load the tissues at a high intensity that they need to start building those foundational bits of strength. And so we use it a lot early on, and then as the body heals and is able to take on more load, we then kind of move away from them. But what's really cool is that, it's an idea that you can get gains from muscle mass to trying to delay muscle wasting in these populations when people aren't ready for those really high loads, thinking like 60 to 80% of a rep max, to speak in a little bit of XPhys, strength and conditioning kind of focus. And so essentially what BFR is, for those who don't know or maybe heard about it in PT school, didn't have a chance to use it or go beyond just a lecture on it. I know in my program, we had the opportunity to talk about it, and then we had a unit in our program, so we got to use it as well. So I got to experience it then, and then I really didn't get to come back around to it until I was in my current clinic where I practice. And so essentially it's taking a pressure cuff, some type of limb occlusion device. Usually it's pneumatic. It's kind of like getting your blood pressure taken essentially. And you take out a certain level, a certain percentage you occlude the limb to that percentage. Usually I use it a lot with the lower body, so it's somewhere between 60 to 80% of occlusion. And then the idea of it is that we take that away. And essentially, I like to think about it as like a supply and demand. So we're going to have a patient do an exercise, and anytime when we exercise, our muscles they demand oxygen, nutrients, blood flow, like they need those things in order to keep us going. And with the cuff itself, we've kind of taken away some of that supply. So the muscles start asking for things that we just don't, we're not giving it in a way. And so that kind of teeter-totter kind of flips a little bit. The demand's not there, but we're still demanding a higher, that's what kind of creates that higher intensity. We're creating an environment where the muscle needs more, but we're not giving it, but it still's got to work anyways. And so what's really cool is that at lower intensity activity, let's say like a bridge or a straight leg raise or some like simple beginning progression you might use with a patient, applying BFR, we can see that exercise is less intense, but that might be the exercise the patient needs in that moment. We apply the blood pressure cuff or the BFR cuff, and you can see people have gains as if we were loading them at 60 to 80% of their 1 rep max, which is pretty crazy to think about. Is you can take something simple and take a piece of technology and dial up the intensity and start to build those blocks of strength in that population. So I think that's where it's really cool to think about how this technology can be applied across the spectrum, across populations of people, across age ranges, and really start to build those foundational strength pieces and then be able to move on when they're ready to do so.
Mm-hmm. And speaking to what you just said, Kelly, you mentioned this is applicable across different patient populations, because originally I think when I was first learning about blood flow restriction, it was very much in an orthopedic, kind of younger, more athletic patient population. And what I have come to find, especially through this article, is that BFR can really be used in many different patient populations, including a really wide age group. They talk a little bit, and I'm sure you can speak to this more in your practice, about you don't have to be this young, fit person to benefit from this. In fact, we're seeing some really impressive gains, like you talked about, even in our elderly patient population.
Right. And if we think about who on average gets a cancer diagnosis, it's typically our older population. Not
Absolutely.
to leave out our AYAs. They exist. They're out there. Their numbers are huge as well. But on average, we're going a little bit later into the lifespan when we're thinking about a cancer diagnosis. And so what I really like about this article and this kind of review of what's out there is that they highlight, we've seen BFR applied in our older adult population, and whether that's postoperatively or kind of more maybe even general, like a deconditioning situation, seeing these gains in lean muscle mass and hypertrophy and reducing risks for sarcopenia, all these things that we talk about in school a lot and even just in clinical practice that happens as we age. And our bias is, we've got to continue moving. We've got to continue exercising. This is why strength training is important, so that the older we get, we know that it will decline, but how much can we slow that decline so people can be as functional as possible? And this is really where this technology comes into play, is that we can take this, and if at the time they're not ready to be loaded, it's not that we don't load them. We do. We make it intense in order to drive change. And we can use this to kind of, in the meantime, augment what we're getting and still get what's so crazy and mind-blowing is we still get the same gains as if I took 75-year-old into the back and got them underneath a barbell. Like if we found that weight for them, that's truly that rep max. However you would look at it, whether it was a true 1 rep or 6. Sometimes people for safety use like 6 reps or 8 reps. We can take that information, that knowledge, and take this technology with it, and you can actually take something a little bit more simple, a little bit less intense, but get the same gains and get the same bang for your buck. It really provides, I think, an opportunity to be a bridge to something I'm all about getting someone underneath a barbell or getting them with some weights in their hands. Absolutely. But if they're not ready for that in the moment, and I still know that they need to build strength to get there, then this technology is a great way to bridge that gap. And you can work on the foundational movement skills that get you to the squat, the back squat, or a kettlebell squat, or whatever you have in your clinic, whatever you have access to. You can take BFR, you can work on those foundational movements. It'll be intense for them. You can start building that base, and then you use that as your bridge to get to load them more when they're ready. And so I think that's is really, really cool to see it applied in our older population that has other diagnoses in their medical history. They chatted a lot. They wrote in the article, like having this stuff applied to people with like COPD. And so you're also looking at them applying this technology to make it safe, not only for considering aging, but also considering as we age, some people have more comorbidities in their history. Is it still safe to apply this technology to get the gains that it offers in these populations where you've got a patient that has 3 or 4 other diagnoses, whether that's diabetes and COPD, and I think they discussed very briefly, like in terms of like AIDS as well. Like they try to find some populations with multiple comorbidities or just a single comorbidity and apply it and see the same gains, improvement in physical function, improvement in your strength, improvement in lean muscle mass, improved frailty scores. They see these same gains regardless of the patient and some of their medical history. So I think being able to move in this direction in our oncology population, where they are not any, they are different, but they're not any different. They are potentially an older adult. They have potentially other comorbidities aside from their new diagnosis. And we're just adding that into the mix. And so the question that they're really looking for is like, how can we, in this article, what's out there and how do we bridge that gap to bring this technology to this population that deals with a lot of the same problems? We're just adding a new diagnosis and new treatment that may happen, which only further increases their risk for all the things we're trying to avoid with aging. Sarcopenia, loss of bone mass, trying to improve their risk for frailty, allow them to be as functional for the majority of their life as much as possible. We're dealing with all those same things. We're just adding this nuance and new set of diagnoses into the equation.
So for the listener and myself, because as Kelly and I talked about off air before we started the interview, I've never done BFR in clinic. I've heard about it. It sounds cool, but I've never thought that it really applied in my patient population until now. When you have decided, Kelly, okay, this patient, and this can be, again, a very general orthopedic patient that you've worked with previously, when you've identified that this person would benefit from blood flow restriction as part of your other physical therapy interventions that you're doing, what does that look like? Can you kind of run us through, like, what would a session with you using blood flow restriction look like for a patient?
Sure. So I can actually use like a little bit of like a case example.
Excellent.
So I've got a patient that I've been treating. I use it a lot in our post-operative population. That's really anyone that I feel like will tolerate it. But this patient in particular, I met him a little bit ago. He had some type of bone tumor. I do not remember what kind of tumor it is, but had a bone tumor in his femur. Ended up leading to tumor resection in terms of his treatment. And then as a result, because they resected so much, they ended up just doing a hip replacement. So this guy's in his 60s, he's like in his early 60s. I think he's like 63, 64, has had a hip replacement as a result of a bone tumor. And so he kind of falls into this population of he's had some form of cancer. his treatment was resection. I do not believe he had any other forms of chemotherapy or further treatment following resection. But then as a result had to have an orthopedic surgery on top of that. So he kind of falls into these two buckets, where the bucket I would totally be like, all right, he's an active guy, plays tennis, plays pickleball. Like he wants, like, those are his goals. He wants to get back to that after healing from the hip replacement. And so for him, the biggest things coming in is like, okay, knowing that the reason why we even had a hip replacement is from a cancer diagnosis. So kind of collecting that information on, resection was the only thing they had to do. How often is he following up with his oncologist? Then I'm kind of sifting through, like, okay, what other, just like we would do as a regular as any other therapist would do, sifting through, okay, what other comorbidities are we dealing with? He's a very healthy guy. He doesn't really have much else going on. But some of your patients may have, when you're thinking about blood flow restriction, you're thinking about making sure that they don't have, you're thinking about hypertension. Is it controlled? Do they have other like vascular issues? Do they have a history of vascular issues, a history of clotting disorders in their family or in their history? You're kind of sifting through that as you think about, okay, this technology, how do I apply it? How do I be safe when I apply it? Even in some of our older population, like I even think about, like, as your skin loses some elasticity or they're on some type of, anticoagulant, they may bruise easily. And this cuff is going to get, I always like to educate them, like, the cuff gets it'll get tight. It gets a little uncomfortable. And so then you kind of got to monitor, like, are they someone that's going to really bruise easily? And so the application of the cuff is you have to consider it from that angle as well. So you're kind of, before you even apply it, you start talking to them and educating them on, like, we have this technology in our clinic. I think it would be a great way to kind of start building that strength foundation for you when we're not quite ready to really load you up, because your tissues are healing. And from a safety perspective, it would be negligent to put you underneath a barbell or put you underneath more load. But this is a way we can, it's a technology we have, and it's shown great benefits to get us started. And so then you're kind of making, from a safety perspective, there's other, like, those considerations from a vascular standpoint. Have they had a surgery in the last 2 or 3 weeks, in the last month? Have they traveled for long periods of time? You're checking those boxes to make sure that there's not any risk for DVT or PE, doing all that safety check. And then you say, okay, when I typically educate them, I say, all right, we have 2 units in our clinic. So one of the units is a Delphi unit, Delphi, like DELPHI, which they use that in their article, or in some of the other literature they looked at, uses that device. So essentially, it's like this little, it's a little box. It kind of sits on what looks like an IV pole. And so I'm going to call it like a continuous cuff. So it's connected to the pressure. The cuff itself is always connected to the monitor. So it's kind of, even as the person's moving, it's constantly adjusting the pressure to meet what you set it at, which is really cool, because you always know, no matter what you're doing, if you've set it up to stay at 60%, it collects that highest pressure value for the patient. And then it's actively, like, basically revolving, like resetting itself to, no matter how the pressure changes when they're moving or exercising, it's changing all the time to meet that 60%, let's say, for an example. So that's one unit we have. And what's nice about it is it does that. The difficult thing is that you have to keep them attached the whole time. So there's only so much tubing to go. So you're getting, and making sure as they're moving that it doesn't come out. And so there's some, like, logistical things about having it constantly be attached, which can get in the way a little bit, but not too much. And then the other device that we have that I didn't know existed until I got to my clinic is called Suji, SUJI, which I don't think they talk about in this article at all, but it's a device that it's actually detachable. So you put the cuff on, you plug it in, you create a profile for the patient. So that's where, when it calibrates, it collects that highest pressure. And so it saves that. And then you don't ever have to calibrate it. Well, I don't say you don't ever. Let's not. You can calibrate it as you see fit. So sometimes if they've had a surgery and you notice, they have some of the atrophy in their muscle atrophy in their limb really early on, you may decide further along to recalibrate if you're noticing that the muscle size is increasing, just so you're getting the most accurate results. But you put the cuff on, you calibrate it, it saves that information into their specific profile, so that if I apply it, let's say a week later, and I set it to 60%, it's going off of what's in their profile, and it's gonna inflate the cuff to 60%, and then you unplug it from the actual pressure device. So then they're free to move around.
Okay.
So that's the one I feel like I default to a lot, because it's really easy to just plug it in, set it up, take it off, and then they can kind of move about, and we just bring it with us. We just bring that with us if we deflate. So that's kind of how it's set up. And so you do a calibration process. So that's where I kind of educate the patient. This is as tight as it's going to get on your leg. And then every other time we're using it during exercise, it should not be getting this tight. If you find it gets this tight, you let me know. Like, obviously, technology doesn't come without its faults. So we're always making sure that it's kind of running the way it's supposed to. And then kind of to your point that you'd said earlier, there's not a lot of, if you go digging into the BFR literature, you'll find different protocols in terms of intervention and doing, like, the most common one you'll see a lot is typically it's 4 sets of exercise, 30 reps in the first set. You get 30 seconds of rest in between each set. And then the last 3 sets are sets of 15. So it goes 30, 15, 15, 15. Then you completely deflate the device. You let them rest for a minute or two, and then you can reinflate and then do the next thing. So that's often what you'll see in some of the literature. I know that in this article, they kind of discussed that's a part of the utilizing BFR, is that there's not necessarily, some of these articles didn't necessarily follow really strict, like, sets and reps kind of protocol. It looked like they used a lot of, like, 3 sets of 20 to 30 reps. I'll say that I even in clinical practice go across the board a little bit. Sometimes I'm doing 4 sets of 15. Sometimes I'm even doing, instead of having rest in my sets of that just 30 seconds of nothing, I'll do a superset. So I might be doing, I'm going to throw out an example. I might do a squat I might do 4 sets of 15, but I'll do a squat for the first 15 reps. And maybe I'm more so biasing the quads. And then I'm doing a single leg RDL, or maybe I'm doing a bridge variation or a thruster variation to get the hamstrings and the glutes. So I'm kind of using the rest period for the muscle group. So resting the quads while I work the glutes and the hamstrings, and then they're going back to the quads. So you can kind of play around. I have definitely used a little bit of liberty, I guess, with how I use it, as long as they're getting some rest. And then after the 3-4 sets, you're deflating fully. And so that's kind of how the treatment session will go.
Yeah.
And as you're kind of bridging into more activity, that doesn't necessarily, you're able to load them more, so you don't necessarily need to use the BFR cuff. You may still just use it. I find that I kind of start with using it, or I don't use it, and then I might use it at the end, or, you can kind of play around with how you kind of bring it back. You take it out of the equation, and then you're just loading the patient the way, you would be, because their tissue, they've come to a certain point in their healing process that they're able to tolerate it. And then you can kind of move away from it.
So this might be a silly question, but you mentioned for your patient earlier had the tumor resection of the femur, then led to having a hip replacement, where exactly are you putting the cuff on that person? And then what muscle, like, are you working muscle groups that are right at the site of that blood pressure cuff? Are you doing distal to the cuff? Like, again, I have never
Yeah.
used it before. Walk me through these like super silly basic questions.
Yeah. So the cuff for the lower extremity, you're trying to get it up as high as you can. That's comfortable. So upper thigh, and then so that's where it's applied and calibrated and then utilized. And then same thing with the upper extremity. So you're going to get it as high as you can up here on the arm as well, in order to use it. And so so you're working I will say you work all the muscle groups, but where the cuff is, you're usually getting those benefits distally
That makes
from
sense.
the cuff. So like for him, for example, the difference in his quads on both sides, size wise, atrophy wise, very easily to be seen. So I put the cuff on and we're going to do, resisted knee extensions, set up the resistance, and we're going, sometimes I'm for him might be 4 sets, 30 reps, 15, 15, 15. And so then we're getting those benefits distal to the quads. Obviously, we're working him in that example, but you're getting the hamstrings. You could do it and do a calf raise. Like if someone was dealing with a Achilles issue, like an Achilles tendinopathy, you could still put the cuff on the upper part of the thigh, and then maybe you're doing some heel raises. I mean, that's also probable that you are occluding the vessels down the stream.
Right.
So you're getting those same benefits if you're working some of those other groups as well. Anything below really is what's being affected.
And how, again, I'm not asking you to be like results in 2 hours or less, but how soon are you kind of seeing these results for your patients in those gains we've talked about previously?
I would say on average, you're looking at 6 to 8 weeks to start seeing them change. I know in this kind of literature review that they offered, their programming was 12 weeks. So anywhere from probably, depending on the condition of, I would say it depends, depending on the condition of the patient, when they're entering in this case, they're entering these studies, but when they're entering your care, I would say, some people that are maybe a little bit more deconditioned may start seeing some jumps pretty early on. But, realistically, anywhere from 8 to 12 weeks application, you start seeing some at 6 to 8, then you're really seeing some noticeable differences in, some of the things they're looking at in this article. They're looking a lot at different circumferential measures. They're looking at, body composition. They're doing, I know, and initially early on they did like a DEXA scan. Obviously they could repeat a DEXA scan. That's really hard to come by in some settings, but if they're going to repeat, that would be gold standard. But they're using a lot of anthropometric. That's the word I was looking for as I'm talking about these things. They're using those measures, those field measures, like circumference and maybe even skin calipers, if your clinic has them, to kind of see the changes. So it does still take a good bit of time to drive some change. But it's like, okay, we could use this technology and use it for 8 to 12 weeks and see some benefits when the patient's not ready to do some of the higher level things. And then that helps them be more ready to do those higher level things later down the line. If we don't use it and we're still not progressing away from lower intensity activity, then what have we been doing for 8 weeks? You could beg that question. How are we bridging them to the more higher intensity activities that will drive traditionally? If we're going to go the traditional route, how are we going to bridge them? I think that's where we get really creative as therapists, which is really cool. And you start seeing these different areas start to collide. I mean, you're talking about driving strength gains, and I mean, I'm not a CSCS or I don't have a huge strength and conditioning background. I'm growing in that area, but you start seeing that world collide with some of this kind of stuff. You start seeing physical therapy collide. I mean, you see a lot of different realms, medical stuff. It's all kind of colliding around these topics and this technology, and how can we use it to help our patients get better and drive change. It's really cool, but it can be. I'm not even perfect at explaining it or utilizing it. I get better at it every day, trying to think through it and apply it to the right patients. But I mean, it's to bridge that gap quicker for us so that patients can get back to what they really want at the end of the day is the goal.
Right.
Being better each time you do it and apply it.
And even as you were talking about some of those things, Kelly, a patient popped into my head, and I'm sure there's multiple patient cases, but this particular patient underwent breast cancer treatment, came out on the other side, and was extremely deconditioned. And this patient, I mean, we worked together for months to try and build up her strength. And unfortunately, there were a lot of different issues that were contributing to this. But it makes me really question what kind of benefits could we have seen because this patient was not able to tolerate those higher loads, like the increased weight that I really wanted to get her to as she's doing these different strengthening exercises, etc. And so it took a really, really long time for us to build up her strength. And I think this is a great clinical kind of example of what the authors of this particular study were, they introduce as part of the why we thought to do this, why we're, compiling this information in this literature review, which is BFR has been used across different patient populations with varying disorders, varying diagnoses to help improve strength and then prevent or delay muscle wasting when the muscles can't tolerate higher loads. So it works in other patient populations. We also know that exercise is beneficial and important for people who are diagnosed with cancer and are long-term cancer survivors so that we can address some of these side effects and impairments as a result of cancer and cancer treatment. Okay, this is kind of coming together. But the big but is cancer survivors may be hesitant to engage in these higher loads. They may not be able physically to engage in these higher loads. So how can we ensure that they are seeing that they are going to get those benefits of the moderate to vigorous intensity exercise that we know and love to talk about in oncology when they're not physically able to do that? And so this really brings us back to the article that we've been dancing around this whole time. And I really want to get into specifically, Kelly. So in this article, the authors identified, so again, this was like a literature review. They wanted to identify what are the benefits of BFR in oncology patients. They wanted to see how it could affect muscle strength, endurance, and hypertrophy specifically in oncology patients, and then also identify safety concerns, which I'm not going to lie, I didn't even consider any safety concerns with BFR because that's just, again, like, I don't know what I don't know because I don't use BFR. So as you are looking through the research, first of all, why did you identify this particular article? What excited you or, interested you about this particular article?
I think kind of a lot of what we've kind of talked about earlier is I've utilized. It's like sometimes when I think about where I'm at in my journey of growing in the oncology rehab setting, it's like they start talking about these treatment regimens and I'm like, I don't know what that is. I don't have the knowledge base to understand why they're doing this treatment regimen with these 6 different chemotherapy medications and how it's affecting the body, etc. It's like, okay, that's a little bit too big, at least for now, it's a little bit too big brain for me. I haven't gotten there yet. But what really struck me was like, I was like, oh my gosh, I use BFR in my clinic. Like, this is a technology that I've learned about, that I've gotten to apply as a therapist. And now we're looking at it in this population I want to grow into. Okay, I already have a baseline understanding of what this technology can do. So I had some of that that foundational knowledge. So I was like, all right, well, let's see what they have to say about it. In my head initially before reading was like, well, heck yeah, of course it would be beneficial. Okay. But also thinking like, are there any big and scaries that we need to be mindful of or avoid or altogether? So it was like, okay, there's some things I know, and then there's some things I'm really curious about. And so as I read it, this idea of like, of course, this patient with a cancer diagnosis may have they're at risk for all these other things like everyone else. And I would probably argue that they're at a higher risk for these things based on their diagnosis and their treatment regimen, because it just, if they're fatigued and they create this, if this negative cycle gets created where they're the common other, side effects and adverse effects of treatment, like fatigue, doesn't mean that when you're fatigued, you don't really want to exercise. You can't really tolerate higher loads. And then it just kind of repeats itself over and over. Then you don't move. So then you have more fatigued, and then they start looking at those things of like how this could help with cancer related fatigue. How could these things help with all the other things, sarcopenia, myopenia, frailty, all these things that normal populations deal with, but also these newer populations, like our patient with an oncology diagnosis. How can do we see the same thing? So it's like, all right, well, that's a good experiment. Let's see if we get the same gains. I would love for us to see that. Which they start showing a little bit in these 5 articles that they kind of selected out after they went through all of their methods and figuring out which were eligible and which were not. But then it also begs the question, there's only 5 articles that talk about this use of technology. And out of the 5, a couple of them were mostly with abdominal cancers. And then you also have I think there were 2 that talked about breast cancer specifically. Some were you could get into the nitty gritty of like all the different articles. Some were post-treatment, some were actually pre-treatment, or the patients were awaiting some type of surgery in their treatment regimen. So I thought that was interesting of like, I think it opens the door of like, when is the best? Okay, BFR is safe. They didn't really have a lot of adverse events. They saw some good things happening, like decreased time in the hospital, keeping some of their lean muscle mass, reducing some of their fatigue because they're able to exercise with lower intensity intervention, but the use of BFR gives them those benefits of higher intensity.
Right.
But it's like, when's the timing? Should we do it? Should it be pre-surgery? Which I would argue, yes, of course it should be pre-surgery. How much can we build them up so that they can tolerate treatment, whatever that treatment is, tolerate treatment. And then some of them were post-treatment. So it's like, okay, well, of course, that makes sense. If we're seeing these benefits and it's safe, like, let's use it then so we can kind of minimize any effects that happen after the fact. I think what's interesting for me is, one, I know this technology, I'm learning this technology, I'm utilizing this technology as a clinician. There's not enough literature in this population of people that I'm interested in. I think it would be really cool to explore on even deeper level, get some more studies out there to show that 1, it's safe. 2, we're seeing those benefits continuously, repeatedly seeing those benefits in this population. That just adds more evidence that this can be used. And so anyone out there that's listening to this that has that interest themselves, please reach out to me, because I would love to partner in that. But I also think what's really cool is that timing piece. It's like, I know that I was shadowing in a hospital system, but I was on the outpatient side, and they do a lot of pre-treatment kind of assessment, risk kind of assessment of where the patient is in that moment, but also this kind of like risk, like almost to answer the question of where are they at baseline? Could they tolerate the treatment regimen that they're going to go under? And so that is really cool to see the therapist. I was observing her do one of these kind of initial consultations, evaluations of where this patient is at baseline, and then kind of sharing, like, I send my recommendations on how physically they present, so that which can give the medical team information of how they're going to tolerate this treatment if they receive it in the next 8 weeks or whatever that time frame is. And how cool would it be to be like, all right, at baseline, this example, this patient, the therapist thought, she's kind of teeter-tottering, almost not ready to tolerate this treatment potentially. I think she may need 6 to 8 weeks of intensive therapy to be ready before they go in and do the whole shebang. And I was like, well, after reading this article, being like, that timing piece would be really important. And they talk about prehab or rehabilitation. What if this patient had access to 8 weeks of structured exercise using BFR? Would that on the back end make them, one, tolerate treatment when they had it, and then on the back end prevent any complications, and then whenever they were safe and ready to reinitiate this, they could go through another 8 to 12 weeks of treatment of utilizing BFR and start trying to build those blocks again after they've already received treatment. I think which I think would be really, really cool to see longitudinally how that would benefit a patient. I think where it also gets a little interesting, where I have questions are, is there a way? It probably depends on a lot of things. It's like, how do we utilize this in the acute setting, if possible, to mitigate the effects of treatment? Now, I recognize that, when they're undergoing their treatment, there are a lot more factors. Their numbers their lab values get thrown off. It may not be feasible. Potentially, we don't know, the literature's not there. It may not be feasible to kind of utilize as treatment is happening. I think a lot of other literature in the population and oncology population goes towards like, what can we do to mitigate the effects of treatment so that they're not as bad on the back end afterwards.
Yep.
And so potentially this technology is an option. It definitely depends on a lot of things. I was reading it and then going back to the Malter article and just speaking of safety and just kind of looking over that article as well and being like, all right, there's patients that will have these risks and effects after a treatment cycle. Are these things adverse events with BFR training? Would you have to teeter-totter a gray area? And so that's even a question that I don't think has gotten looked into enough either.
Right.
How would it be to apply it during treatment? But I definitely feel like pre and post, there's opportunity.
Right. There's pretty clear opportunities based on that article. And I really appreciate how, we've talked about getting patients to the point that they could be candidates for some therapies. This is a really big concern in various patient populations within oncology. I'm thinking when it comes to like abdominal surgery, that's a pretty big one I hear about. Also, even lung cancer, for some patients, their condition, their physical function and condition may be the factor that says you're not a candidate for these surgeries. And so this is part of why, this is one of the big pushes behind prehab and has been for so many years of we could help patients who are not candidates for, again, surgery or whatever, become candidates. And we know that, when a person is able to undergo cancer treatment, then they're better, their chances of survival on the other side are much greater. Can we utilize this tool, BFR, as a way to not only get patients to be candidates, but maybe help them become candidates faster, for example? Could we help, even patients who are not candidates, even with physical therapy outside of BFR? Could BFR be the factor that helps them then become candidates for these major procedures like we've talked about? Again, I think that's a little more of the hypothetical, but I think this is laying the foundation of these are the questions that we're now starting to ask of. based on, this limited literature review, which they do acknowledge that in the article. I don't want anybody listening to this to be like, oh, everything's hunky-dory, rainbows and sunshine. They do a great job of acknowledging some of these limitations that I can appreciate from the oncology side, but there's still great support, it seems like you said, for prehab especially, and of course on the post-treatment end. So I think there's a lot of opportunity, but again, we really need more research to kind of determine what is that optimal dosing and prescription for our patients? What is the timing, like you mentioned, Kelly, on when is it really best for our cancer survivor to be undergoing this treatment as, kind of within the realm of their oncology journey? Were there any parts of this article that maybe surprised you or, you weren't expecting as you were reading through this?
So I think one of the things that surprised me is a quote from the article, is regardless of the benefits of exercise, many oncological patients are hesitant to engage in working out due to concerns about exacerbating symptoms or causing harm to their health. And so why that surprises me is that there's so much literature out there that supports exercise just at baseline. Exercise, I think a lot about how a patient can respond when you're like, you're feeling the effects of cancer-related fatigue. Well, let's exercise. And you're like, in their head, they're probably like, that sounds backwards.
Definitely.
But then you see in these articles that that apply exercise to look at cancer-related fatigue, and they're seeing it work. And so and amongst other things that exercise in general gives us, better quality of life, improved physical function. Their articles are hit or miss on, affecting more of the like psychosocial aspects of how psychologically how exercise can affect us. It's hit or miss sometimes where you see it doesn't affect it at all, or you see a positive benefit. I've never seen one that's negative, but sometimes you can find that the impacts are not significant. So I think what's surprising is that, at baseline, people are afraid to exercise. They're entering this journey and it's scary, and they've never been in it before. They don't know what to expect. They don't want to make anything any worse than it already is, because it can be, it's getting a cancer diagnosis is life-changing. And it changes not only your medical and physical well-being, it affects you mentally and spiritually and emotionally and socially. And there's so many other layers.
Yep.
And so already at baseline, regardless of how much you're told that exercise is beneficial and it can help you during your survivorship, there's still people that they're hesitant. And then I think with this article in particular and talking about BFR is like, it's a great technology, but you're adding another layer of like, we're going to exercise with this cuff on my arm or this cuff on my leg. Like, I will say I've done BFR myself, and it's not the most comfortable thing in the world. I mean, it's hard, and it's crazy to put the cuff on and even put it, let's say 60% on my leg, and do 4 sets of straight leg raises or 4 sets of bridges. I mean, you feel the burn at set 3 and you're like, oh, I only get 30 seconds rest and I gotta do it again. And I personally myself find what's hard about BFR is not the working, it's the resting, and you're waiting to start again. And so obviously I'm a normal and healthy individual, but it's like, it's not, you're then going to talk to this patient about this technology and how it can help them, just like you talk to them about how exercise can be beneficial for them. And maybe they were a previous exerciser and maybe they weren't. And then you're adding this other thing that's like kind of maybe going to be a little uncomfortable to utilize. And I can just see how that perpetuates this like fear of, I don't want to make anything any worse. This kind of is uncomfortable. Is it harming me or is it helping me? And so I think it really comes down to us educating our patients of like, this is beneficial. If you're open to trying it, let's try it. It's going to be a little uncomfortable at first. That's normal. Even just using your own story of like, I've used it. I've applied BFR to myself. This is how it felt for me. I get it. Set 3 in this is going to suck. I've been there. I've been in your shoes when it sucks. Giving them that reassurance of like, I've done this. I'm not just taking this technology and applying it to you for the benefits and not having any experience myself on what it feels like. So being able to educate them on what it's going to feel like is very helpful. And that's across all patients. That's not just patients with cancer. All patients, letting them know like, hey, this is gonna be a little uncomfortable. And you get to set 3 and you're gonna not like me very much potentially, but it's beneficial, and and also giving them the control of like, even during the calibration process, I say, this is the tightest the cuff's ever gonna get. It's collecting that information of like, so it can use the percentages. This is as tough as it gets, but if we get to, our thing has like 10 steps of calibration. If we get to step number 5, and you're like, nah, Kelly, I don't want it. I'm not feeling this right now. I'm like, ball's in your court. We deflate, we take it off, we move on. Like, it's a technology that can really help us, but if you're not about it, I'd rather you be bought in. If you're not bought in yet, that's fine. Give them the control to take it off. So I think that's also a big piece, is like letting in this situation with the survivor, letting them know, hey, they feel like I'm sure they feel like at times they don't have control about what's going on, because who controls when and if you get cancer? No one. That's what sucks about it. And so I think being able to, even applying exercise or applying exercise in this technology of BFR, telling them, hey, you have control in any moment. If you're not digging the cuff, we take it off. It's fine. We can still find ways to get you better, get you stronger, get you ready for treatment. This is just an option we've got. And if you're open to using it, there's great benefit in it. And if you're not, that's okay. That's what we're trained to do. We have been therapists and have been doing intervention long before BFR was a thing. So we can still do that. We can still do it that way.
Yep.
There's nothing wrong with that. So being able to give them the ball in their court, because it's kind of surprising to be like, you see all these benefits and you still don't want to try it, or you're afraid. And it's just recognizing that it's okay to be afraid if you've never done something before. And there's so many other things that they're experiencing and haven't done before and really shouldn't have to deal with the diagnosis. But, being able to come alongside and educate them. So I think that was one big thing, was like, the evidence is growing, or the evidence is there that exercise is helpful, but people are still very hesitant to it.
Right.
So thinking about why that is, understanding why that is, and how we can educate towards that to help them feel like, okay, we can do this.
Right.
And then applying that same concept to BFR, because it's a new technology. It would be a new technology. They've never experienced it before. It's not always the most comfortable thing to utilize. So working through that discomfort of having the pressure cuff on and giving them that control to take it off.
Right.
I think the other piece was that of the 5 studies they selected, they were most often applied to patients with abdominal cancer and then breast cancer. There were no other forms of cancer being applied to. I know a lot of literature goes towards like breast cancer population for sure, across the board, no matter what you're looking at intervention wise, you're seeing it applied to them. And so I think it just kind of begs us to go in the direction of, how does this apply to other populations? I mean, I think of my patient that I talked about briefly earlier, is that, he didn't have breast cancer, nor did he have an abdominal cancer. He had a bone cancer that led to a hip replacement. So he's a patient with a cancer diagnosis who has an orthopedic condition that we're dealing with. And so I think that is seeing it applied to some other populations moving forward would be I'm surprised it hasn't been applied to some of our other populations yet, but that's just where it potentially needs to go. Or even seeing it applied, I think the lifespan across these articles is pretty large. Like probably, I want to say, if I remember correctly, I mean, you're going from like early 30s all the way to like 70s,
Yeah, it was pretty
80s,
wide.
maybe longer than that.
Yeah.
It's pretty wide window. I think not to forget our AYAs, but seeing it applied in that population, that younger population, as well, would be really cool to see it move into that realm, because it's definitely lacking across the board there. So those are probably the two things really that surprised me. And I think it just goes to show that we still have a lot of education to do with our patients and especially utilizing something new. Just like an oncologist has a new treatment regimen, is going to have to educate and explain the ins and outs of why treatment has gone in this direction, what the patient would expect, would they be interested in participating in this clinical trial with this regimen. We get to do the same. We have the opportunity to do the same thing with exercise and with potentially this new technology of BFR, is educating all the nuances and being well-versed in what the experience is like and what it'll be like for them, and giving them the control to try it out and really buy into it. But also the control to maybe not be ready for it. It's okay if they're not ready for it. We can keep working on being ready for it if it's something that they want to try in the future.
Right. For the OncoPT who has listened to this and is now saying, I might be a little interested in BFR, what information, what encouragement would you give that therapist who is now maybe open to bringing BFR into their oncology practice?
I think one is that the literature we have right now doesn't lie. They're utilizing BFR. Obviously, there's tweaks to make it better research, better trials, more specific, dosage and that kind of stuff, but across the board, exercise plus BFR is improving patient quality of life. It's reducing frailty. It's improving functional capacity, strength, lean muscle mass, reducing post-op complications if applied before, decreasing length of stay in the hospital. You're seeing it can be reducing some of the things we talked about earlier, other things that we fight with aging, decreasing sarcopenia, myopenia, making sure these patients are as functional as possible throughout their treatment and after their treatment. I think that's really, you're seeing it across the board, even just limitedly right now, that there are these benefits for this population of people. You're also seeing that it's safe when it's applied, and we're having limited adverse events. It's not without screening and make sure they don't have some other medical history that may say, hey, this isn't appropriate. But I think going back and doing that quick screen, but also, referencing the Malter article as needed, thinking about some of the other things they're going to undergo during treatment. So if you're interact with them maybe post-treatment and you want to initiate BFR, that it's be mindful of those things too. And, you're constantly assessing, like, is this appropriate? And then if it's not, then get away from it. I think the other challenge with new technology is not every clinic is going to have access to it. So as literature moves forward, you get more evidence in your bank for your clinic to invest in this kind of technology. Right. Obviously, for me, I already had access to it at baseline because the populations that I'm seeing in my clinic is more of that orthopedic sports realm. And I got lucky to have some patients that have an oncology diagnosis, and I can apply it to them. So I get to see this in action and see the benefits of it. But I recognize that if you're primarily seeing let's say, outpatient oncology population. You may not, this is something your clinic probably doesn't
Mm-hmm.
have. And so as literature comes out, like maybe you're making a proposal to your team about investing in a device, which I think would be amazing. So being able to see that we're pushing for more literature in this direction to see further what benefits are allows you to make that proposal in the future. So like keep on keeping on and looking for that. And then and even with that, it comes down to there's different devices out there. So you start having to kind of go into that wheelhouse of like, what's the best device or what's the most economically feasible if I want my clinic to invest in it. So then you start building relationships outside of the physical therapy world. You start building relationships with like companies
Mm-hmm.
and manufacturers that are making these devices. You're building relationships with the reps. Just like we would have a rep come into your clinic and talk about something that they're selling, a certain type of compression sleeve or whatever that a patient might utilize, we get to start those relationships
Mm-hmm.
potentially to have our clinic spaces buy into this kind of technology. So I think that's really exciting. There's a lot of direction that this topic needs to go. It's looking promising so
Yep.
far. And I think we continue to ask for it to move forward. And, my extra plug, if anyone else out there is interested in this, please reach out to me. I would love to kind of connect on this stuff on a deeper level about utilizing BFR and pushing this literature forward. So we get more than 5 articles out there talking about its benefits and where it can be applied. I think it's really, really awesome to potentially get patients ready for treatment, or if it's possible to utilize in treatment, that's to be determined. But then even post-treatment, being able to safely apply it post-treatment as well to help these patients live their best
Mm-hmm.
lives.
And if you, the listener, are interested in continuing this conversation, like I mentioned at the top of this episode, this article was selected as part of our ongoing research roundups that we do within the OncoPT specialization community. And that community is free for anyone to join. I have linked that in the show notes for today's episode, and you will find this article and many, many more that we are continuing to work through together. These research roundups are ways that you can get your hands on kind of bite-sized information. What is happening right now in oncology, rehab, research, and how ultimately does it apply to your practice? A few months ago, I had a podcast guest on who talked about how it is so overwhelming to try and comb through the research on your own when you've already got X, Y, Z number of things to do. This is just one way that we're helping you get your hands on the information, what is current and new in the literature, and then how can you actually apply it to your own practice. So again, this article and more are available on our OncoPT specialization community. That link is in the show notes for you to join. And Kelly, thank you so much for coming back on the podcast to talk about this. This was an outstanding topic to really get into, especially as someone who doesn't have experience with this and hasn't used it in practice. But the benefits are definitely there. And again, I'm thinking back to that one patient that I worked with so many years ago. How much further, how much faster could we have gotten to where we were trying to go with this kind of technology as an intervention alongside the other stuff we were working on? And I do think that we could have seen some more benefits, some, maybe accelerated benefits for this patient. So thank you so much for coming on today's episode. We so appreciate you sharing your experience and your knowledge with us. Is there anything else you want to leave with us today?
I think it's always a pleasure to be able to get on here and, practice, looking through the literature, applying it to reflecting on my own clinical practice, how I can be better, how I can utilize this technology better, and being able to start conversations with you, with other people in the cancer rehab community about making rehab better, cancer rehab better. I think it's really, really fun to grow in that way and start some awesome conversations with people about utilizing things or trying new things so that ultimately down the road we're better for it and our patients are better for it.
Absolutely.
So it's always an awesome opportunity. So thank you for bringing me in.
We will definitely be having Kelly back on the podcast in the future, so don't you worry. But until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.